Okay, welcome back. In this lesson, we continue with further classification of burning mouth syndrome. And by the end of the lesson, you would be able to explain the following terms as applied to BMS: primary BMS, secondary BMS, peripheral BMS, central BMS, and complicated BMS. It is known that the pathogenesis of BMS may involve at least some form of induction of neuropathic mechanisms. And when such inducers are unknown, Scaler and his team in 2003 classified these BMS types as primary burning mouth syndrome. And on the other hand, when specific inducers or activators can be identified, BMS is classified as secondary. These activators could be in the form of local oral pathology or systemic pathology and may include infections, tumors, local allergic reactions, intraoral ulcers, presence of intraoral prosthesis like acrylic dentures for instance, autoimmune diseases like Sjogren's with xerostomia, nutritional deficiencies, endocrinopathies such as thyroid disease, diabetes mellitus, and sometimes even certain drugs used chronically by the patient. As you would expect, this multitude of disease associations makes the management of BMS patients multidisciplinary and also makes primary BMS a diagnosis of exclusion. This means to make a definitive diagnosis of primary BMS, you first have to rule out secondary BMS. The pathophysiology of primary BMS is thought to involve some neuropathic alterations in both central and peripheral nervous systems. Central nervous system alterations often result in hypofunctional dopaminergic connections in the basal ganglia, as we'll see in the next section. And BMS resulting from this is subgrouped as central BMS. On the other hand, alterations in the peripheral nervous system involves various forms of degenerative neuropathic mechanisms affecting the trigeminal nerve and its terminal branches. And BMS resulting from this is subgrouped as peripheral BMS. This subgrouping, that is central versus peripheral, can have therapeutic implications because whereas symptoms in peripheral BMS patients may respond to local therapies like lingual nerve blocks or lidocaine patches or even topical creams like clonazepam, central BMS patients will achieve a better response when administered systemic agents. The reality, however, is that some patients may exhibit both peripheral and central pathophysiological mechanisms as a reason for their BMS. These patients will therefore require both topical and systemic medications in order to alleviate their symptoms. Now, obviously, techniques for making such specific diagnoses are not yet routine in clinical practice and may include investigative procedures like functional brain imaging and structural analysis of the nervous system, which sound not only complex but expensive as well and are more often used for research purposes. Let's now move on to look at what complicated BMS means. Let's start with the clinical scenario here. Now imagine you have a patient complaining of burning oral pain in your dental clinic. You perform all your examinations, your test, and then you find out that he has intraoral candidiasis. So then you went ahead and made a diagnosis of secondary burning mouth syndrome, that is burning secondary to the candidal infection. So then you started treatment for this patient with antifungal agents, and after 3 to 4 weeks, the candida has been eradicated. The only problem though is that his burning pain still remained and has not seen any improvement at all. Now such a case, which looks like a combination of both primary and secondary BMS, is known as complicated BMS. And after successfully treating the secondary lesion or disorder, complicated BMS will be managed as primary BMS. This brings us to the end of lesson 4. You may now move on to lesson 5. Do not forget to mark this lesson as complete.